Good morning. Myself, Dr. Yash Kotecha, Assistant Professor, C.M.P. Shah, Government Medical College, Jamnagar. Today's lecture topic is jaundice and hepatic failure. This is our second lecture topics. After that, we will see hepatitis, cirrhosis, and all. So, what is objective of today's lectures? We will discuss two topics. One is jaundice and second is hepatic failure. About jaundice, we will what is the definitions and normal value of jaundice, how bilirubin metabolism occurs in our body, how we have to classify the various types of jaundice, what are the lab investigations in various types of jaundice, and what is the neonatal jaundice. We will discuss that. And in second part, we will discuss hepatic failure. So, definition of jaundice. Jaundice or icterus refers to yellowish pigmentation or discoloration of skin and sclera by bilirubin pigment. So, it is yellowish discoloration or pigmentation of skin and sclera. Here you can see normal white color sclera, and this is yellowish discoloration or pigmentation you can see. This yellowish skin either may be due to carotenemia or rifampicin therapy. Where else we can see jaundice? We can see jaundice in palms, soles, palate, under surface of tongue because bilirubin pigment has a high affinity for elastic tissue and as jaundice is particularly noticeable in tissue rich in elastin content. Okay. Now, what are the normal values of bilirubin? Normal value of serum bilirubin is zero point 0.3 to 1.3 milligram per deciliter, and parts of total serum bilirubin are unconjugated bilirubin and conjugated bilirubin. Component of unconjugated bilirubin is zero point 0.3 to 1.0 milligram per dl, and component of conjugated bilirubin 0.0 to 0.3 milligram per dl. So 75 to 85% it is unconjugated time and 50% it is conjugated time of total serum bilirubin. And jaundice becomes clinically evident when then the total serum bilirubin value exceeds 2 milligram per deciliter. See, normal serum bilirubin value high is 1.3 milligram per day. Up to 1.3 milligram per deciliter, it is normal serum bilirubin. And serum bilirubin exceeds when 2 milligram per dl, we can see clinically evidence of jaundice. Between 1.2 to 2.0 milligram per dl, it is not clinically evident, but by doing lab investigation, you can see elevated serum bilirubin level. It is known as latent jaundice. So, normal value is zero point 0.3 to 1.3, and jaundice clinically evident when total serum bilirubin is 2 milligram per dl. So between 1.3 to 2, it is known as latent jaundice. So jaundice is a result of elevated level of bilirubin in blood. It is termed hyperbilirubinemia. Okay. It becomes clinically evident as yellowish discoloration or pigmentation of skin and sclera due to retention of bilirubin. And cholestasis is somewhat different because cholestasis is characterized by systemic retention of not only bilirubin but other solutes eliminated in bile. So, bile retention means it is cholestasis. You know, we will revise normal bilirubin metabolism. We have seen this is this in first lectures. This is the source of normal bilirubin metabolism. Bilirubin is produced from this senescent RBC. 85% bilirubin is derived from this senescent RBC and 15% from myoglobin, ineffective erythropoiesin and cytochrome C. From this senescent RBC, there is derivation of heme, and this heme in splenic mononuclear macrophage with the help of heme oxygenase enzyme, it is converted into biliverdin. With the help of biliverdin reductase, uh, it is formed in unconjugated bilirubin. This unconjugated bilirubin, with the help of albumin in the blood, they are transported to the liver. So, first step is the source. If there is excessive destruction of RBC due to any cause, it will lead to hyperbilirubinemia. This is the first, and it is unconjugated type because conjugations occurs in liver. Second step, it transport to the liver, and third step is hepatic phase where bilirubin glucuronides are formed monobilirubin glucuronides and dibilirubin glucuronide are formed, and ultimately they are stored in gallbladder. From gallbladder, through the common bile duct, they are secreted into second part of the duodenum, and ultimately with the help of intestinal bacteria, there is stercobilinogen and urobilinogen is formed. This stercobilinogen is excreted in the stools and urobilinogen in the urine. So bilirubin, urobilinogen, stercobilinogen all are different. And why these steps are required? Because these this this unconjugated bilirubin, which is formed from senescent RBC, it is water insoluble and lipid soluble. You have to convert this unconjugated bilirubin in water soluble, then and then it can be excreted from the stool and urine. Okay, so to become the end product of senescent RBC, heme, you have to convert into lipid soluble to water soluble, then and then it can be excreted. So you have to convert unconjugated bilirubin with the help of liver into conjugated bilirubin, and it is ultimately stored in bile, and finally it is excreted in urine and stool. So we will revise all four steps. First step is what are the source for bilirubin production? 80 to 85% senescent RBC and 15 to 20% from myoglobin, catalase, cytochrome, and partially from ineffective erythropoiesis. Second step is transportation. Bilirubin on release from splenic macrophage circulate as unconjugated bilirubin in plasma, which is tightly bound to the albumin. Some drugs like sulfonamides and salicylates competes with bilirubin for albumin binding and displace this bilirubin from albumin, and this facilitates bilirubin to enter in the brain in neonates and increase the risk of carnicterus. Okay. Third phase is the hepatic phase where hepatic uptake, conjugation and secretion. These are the three main subsequent steps are there. Hepatic uptake with the help of glutathione as transferase will be there, and second step is conjugation. Here unconjugated bilirubin, which is alcohol soluble, which is and it is converted to water soluble compound by conjugations, and this process can be increased or induced by drugs like phenobarbital, and these conjugated bilirubins from minor bile canalicular surface of the hepatocytes, they are secreted into the bile duct, and ultimately they are stored into gallbladder and intestine. This conjugated bilirubin is secreted either as stercobilinogen and or its metabolite urobilinogen. What is delta bilirubin? There are two types of bilirubin bound to albumin, either reversible or irreversible. Reversible binding is similar to that of unconjugated bilirubin. However, when these reversible bindings means presence for long time, either due to cholestasis or long-standing biliary obstructions or chronic active hepatitis, this conjugated bilirubin is bound to albumin irreversibly, and it is termed as delta bilirubin or biliprotein. Now, why jaundice occurs? Here the steps of bilirubin metabolism. Here is the pathophysiological mechanism, and here the figure shows the bilirubin metabolism. First, step is increased bilirubin production is the source. These are the senescent RBC or ineffective erythropoiesis in case of thalassemia. There is ultimately increased bilirubin production from the source, which is the first step. It leads to unconjugated hyperbilirubinemia. Second step, transport, decrease hepatic uptake. Whatever the reason, if there is decreased hepatic uptake is there, there will be lead to unconjugated hyperbilirubinemia. Third step, hepatic phase conjugation. In these steps, in whatever reason, the conjugation process is not occurring in the liver, that leads to unconjugated hyperbilirubinemia. And fourth step, hepatic phase secretion in the bile. If there is some blockage is there, either intrahepatic or extrahepatic, which leads to decrease or obstruct, completely obstruct release of this bilirubin into the bile, which leads to conjugated hyperbilirubinemia. So there are four steps of normal bilirubin measurement: source, transport, hepatic phase. These three phases mainly source, transport, and hepatic phase of conjugation. Any problem with these three phases, it leads to unconjugated hyperbilirubinemia. And whenever there is secretion of in bile, bilirubin secretion is bile is hampered, it is leads to conjugated hyperbilirubinemia. So we will revise all the causes once again. What are the causes? What leads to excessive productions of unconjugated bilirubin? These are the causes: hemolytic anemia, reception of blood from any internal hemorrhage, or ineffective erythropoiesis like thalassemia. What are the causes of reduced hepatic uptake? Some drugs, anabolic steroids, OC pills, rifampicin, sulfonamides, as we have seen earlier, and barbiturates and caffeine, they increase bilirubin metabolism. Some causes of Gilbert syndrome, which causes reduced hepatic uptake, and impaired bilirubin conjugation. Third step, 3A, either due to physiological jaundice of newborn, genetic deficiency of UDP glucuronide transferase A, Gilbert syndrome, diffuse hepatocellular disease, either viral induced hepatitis, drug induced hepatitis, or cirrhosis, and 3B, defect in transportation, either deficiency of canalicular transport protein in case of Dubin-Johnson's and Rotor syndrome, or impaired bile flow due to any extrahepatic obstruction, which leads to conjugated hyperbilirubinemia. Now we will proceed after completing the causes and normal bilirubin metabolism. We will classify the jaundice. There are three types of classifications: pathophysiological classification, simple age-old classifications, and other classification. According to pathophysiological classification, you can classify it as a predominantly unconjugated hyperbilirubinemia, or you can classify it as a predominantly conjugated hyperbilirubinemia, means cholestasis. As simple old age classification, it is prehepatic and hepatic and post-hepatic causes. Prehepatic means hemolytic causes, hepatic means hepatocellular, and post-hepatic means cholestatic or obstructive. And other surgical treatable causes means obstructive, and non-obstructive medical treatable is clinical. Either surgical jaundice is there or clinical jaundice is there. Nowadays, we are following pathophysiological classification most commonly, which is predominantly unconjugated or predominantly conjugated hyperbilirubinemia. Now, predominantly unconjugated hyperbilirubinemia, we know all the causes. Increased bilirubin production is the first cause, either due to hemolysis, ineffective erythropoiesis, and in neonatal jaundice. Decreased hepatic uptake, either deficiency at the liver, GST or ligantin, or there is a drug, prolonged starvation, or sepsis, which leads to this step. And decreased bilirubin conjugation, step 3A, either hereditary disorders like Gilbert syndrome, Crigler-Najjar syndrome, acquired deficiency, and neonatal jaundice. Here you can see neonatal jaundice is in both causes. First, increased production of bilirubin. Excessive RBC lysis occurs in neonates, which leads to unconjugated hyperbilirubinemia, and there is decreased bilirubin conjugation because there is enzymatic deficiency in early life of neonates, which leads to hamper the conjugation process. So neonatal jaundice step 1 and step 3 both are affected. What are the lab findings in case of hemolytic jaundice? In addition to unconjugated hyperbilirubinemia, serum bilirubin, their value will be 2 to 20 milligram per dl. Absence of urine bilirubin. Why there is absence of urine bilirubin? Because out of this 2 to 20 milligram per dl, most of the serum bilirubin is unconjugated type. This unconjugated bilirubin is water insoluble. If you want to excrete this bilirubin in urine, it should be converted into conjugated bilirubin, which is water soluble. Here, mostly it is unconjugated hyperbilirubinemia, so there is absence of urine bilirubin is there. Hepatocellular cause, no hepatocellular cause is there. So AST and ALT will be absolutely normal. And dark brown stool due to excess bile pigment is there and increased urobilinogen content is there. Here you have to understand, urine bilirubin is absent because most of the component is unconjugated hyperbilirubinemia, but liver works its higher normal capacity. So conjugation is higher and there is conversion of bile pigment into an urobilinogen will be higher. So normal rise in urobilinogen and excess bile pigment formation is there. So dark brown stool is there. You have to understand this because it is mostly unconjugated hyperbilirubinemia in hemolytic jaundice, but there is no defect in liver. So conjugation step is also occurring it as it in high peak. So it will leads to absence of urine bilirubin, but excessive bile pigment and urobilinogen will be there. Second part, conjugated hyperbilirubinemia or cholestasis. They are two types, either intrahepatic or extrahepatic cholestasis. Remember the morphology of hepatocyte. There are three surfaces of the hepatocyte. One facing the sinusoidals and a disc of space facing disc of space. Second one in neighboring hepatocytes, and third surface is canalicular surface. So either there is a problem between this canalicular surface means intrahepatic cholestasis, and whenever there is a problem at the bile duct level outside the liver, or it is known as extrahepatic cholestasis. What are the causes of intrahepatic cholestasis? Either in the form of hereditary disorder or pure cholestasis, or some acquired disorders just like hepatocellular causes. And extrahepatic cholestasis means that somewhat mechanical obstruction is there. We will discuss in detail. So these are the causes: conjugated hyperbilirubinemia and intrahepatic cholestasis. Hereditary disorders or pure cholestasis in the form of Dubin-Johnson syndrome, Rotor syndrome, fibrocystic disease of pancreas, benign familial recurrent cholestasis, intrahepatic atresia, cholestatic jaundice of pregnancy. These are pure form of cholestasis. And acquired means some affecting due to some viral infections, drugs, alcoholic injuries, sepsis, cirrhosis. This will lead to intrahepatic cholestasis. And extrahepatic cholestasis means obstruction is there outside the liver in the form of gallstone, inflammatory stricture, carcinoma of the head of the pancreas which cause the stricture, tumors of the bile ducts, sclerosing cholangitis, congenital atresia of extrahepatic ducts. These are the causes of extrahepatic cholestasis. Predominantly conjugated hyperbilirubinemia is defined as failure of normal amount of bile to reach to the duodenum. Systemic retention solutes not only bilirubin but other solutes in the bile like cholesterols and bile acids in liver and biliary passage. Dilated bile canaliculi, hepatocyte degeneration, distended proliferated bile ducts, bile leaks, portal tract fibrosis, cirrhosis, these are the common findings, and sometimes ultimately this prolonged cholestasis leads to biliary cirrhosis. So, what are the some common features and what are the differentiating features of intrahepatic cholestasis and extrahepatic cholestasis are narrated in this tabular form. There are two types of intrahepatic cholestasis, either hereditary cause or acquired cause, and extrahepatic due to mechanical obstruction, as we have seen earlier. These all are common findings. Conjugated hyperbilirubinemia in both, bilirubinuria in both, increased prothrombin time in both, increased bile acid leads to pruritus, increased serum alkaline phosphatase and hyperlipidemia. See, there is increase in serum alkaline phosphatase. It is enzyme present in canalicular surface, and there is increased prothrombin time in the both. What are the differentiating point on liver biopsy? There is mild degree of cholestasis in case of intrahepatic cholestasis and marked degree of cholestasis in case of extrahepatic cholestasis. There is dilated bile canaliculi is there and there is bile plug formation is there. These bile plug formations leads to shows feathery degenerations in affected hepatocytes, and they are mostly seen in the periphery of the lobules. But in case of extrahepatic cholestasis, there is due to bile stasis, these bile lacs are seen and necrosis of hepatocytes leads to ascending cholangitis mimicking biliary cirrhosis. So, causes of intrahepatic either hereditary or acquired, extrahepatic mechanical obstruction, these all are the common findings. Conjugated hyperbilirubinemia, bilirubinuria, increased PT, increased bile acids, increased serum ALP, alkaline phosphatase, hyperlipidemia. But what is the difference? In on liver biopsy, mild degree of cholestasis in case of intrahepatic cholestasis and marked degree of cholestasis in case of extrahepatic cholestasis. Dilated bile canaliculi will be there in intrahepatic cholestasis and dilatation of bile duct, destruction of bile canaliculi due to retrograde extension of bile is there in case of extrahepatic cholestasis. Bile plug and bile leg. This is the main difference you should know on liver biopsy. So we will revise once again what are the common features of intra and extrahepatic cholestasis, conjugated hyperbilirubinemia, bilirubinuria, bile acids increase which leads to pruritus, increased concentration of ALP, hyperlipidemia and increase in prothrombin time. How you can differentiate pure and acquired? In case of acquired cases, there is increased transaminase enzymes. And how you can differentiate extrahepatic from intrahepatic cholestasis? We will revise the first lecture. Increase in prothrombin time, we have to inject vitamin K in the patient intramuscularly. After injection of vitamin K, if prothrombin time is normalized, cause is extrahepatic, but if prothrombin time remains elevated after the injection of vitamin K, it is intrahepatic cholestasis. Liver biopsy, bile plug in intrahepatic cholestasis and bile lacs in extrahepatic cholestasis. Here you can see accumulation of bile pigment. Here you can see these are the bile lacs. Now, what is neonatal jaundice? Hepatic capacity to conjugate and excrete does not mature until 2 weeks of the age. So, jaundice appears in neonates when the total serum bilirubin is more than 3 gram per dl. It may be result of unconjugated or conjugated hyperbilirubinemia, but most common is unconjugated hyperbilirubinemia. These are the various causes of neonatal jaundice. Most commonly, it is unconjugated hyperbilirubinemia, and some other causes are conjugated. For unconjugated, either it may be physiological jaundice, hemolytic disease of newborn, congenital hemolytic disorder will be there, perinatal complications, some perinatal complication will be there, and these are the two: Gilbert syndrome and Crigler-Najjar syndromes. In conjugated hyperbilirubinemia, hereditary cause, Dubin-Johnson syndrome and Rotor syndrome due to some infection, hepatitis B, C, rubella, and etc. Some metabolic causes like alpha-1 antitrypsin deficiency, Niemann-Pick disease, idiopathic biliary atresia, and Race syndrome. Out of this, we will discuss Gilbert syndrome, Kriegel-Najjar syndrome, neonatal hepatitis, biliary atresia, Race syndrome, and this is Dubin-Johnson syndrome and Rotor syndrome. We will discuss this for hereditary non-hemolytic hyperbilirubinemia, neonatal hepatitis, biliary atresia, and Race syndrome. First, hereditary non-hemolytic hyperbilirubinemia. They are uncommon familial disorder of bilirubin metabolism. See this table. This there this shows features of major hereditary non-hemolytic hyperbilirubinemia, either conjugated or unconjugated. So you have to remember like this: GC and DR. DR for doctor, and this is GC or you can CG. DR it is of conjugated. First, you can remember in this form. DR, it is conjugated non-hemolytic hyperbilirubinemia. But GC or CG, Gilbert and Kriegler-Najjar syndrome, it is unconjugated. First, you have to differentiate like this. Out of this, Gilbert and type 2 Kriegler-Najjar, it autosomal dominant. All other three are autosomal recessive. And intensity of jaundice, it is marked in type 1 Kriegler-Najjar syndrome and mild in type 2 Kriegler-Najjar syndrome, mild to moderate. All others, Gilbert, Dubin-Johnson and Rotor, there is less than 5 milligram per dl increased concentration of bilirubin. And what is the basic defect? In Gilbert's and Kriegler-Najjar's, there is affected part is UDP glucuronide transferase enzyme. Here, there is decreased activity in Gilbert, absence of UDP glucuronide in Kriegler-Najjar's, and decreased UDP activity in Kriegler-Najjar syndrome type 2. So, Kriegler-Najjar type 1, there is completely absence of this enzyme which leads to marked elevation of bilirubin, unconjugated bilirubin. So, there is a poor prognosis in case of type 1 Kriegler-Najjar syndrome because there is completely absence of UDP glucuronide transferase enzyme there. So, it will lead to unconjugated hyperbilirubinemia, concentration more than 20 milligram per deciliter increase of bilirubin. So, chance of cardiac is there and there is poor prognosis. And rest is excellent prognosis, and Kriegler-Najjar type 2 there is good prognosis. Out of these five, in Dubin-Johnson syndrome there is greenish black pigmentations on hepatic morphology you can see because there is a defect in canalicular excretion. We have seen bromosulfation excretion test. This test nowadays limited to diagnosis of Dubin-Johnson syndrome. Once again we are revising. These are major hereditary non-hemolytic hyperbilirubinemia. There are two parts, CG and DR. DR means Dubin-Johnson and Rotor. You can say doctor is saturated means conjugated. You can remember like this. Dubin-Johnson syndrome and Rotor syndrome, it is conjugated hyperbilirubinemia, and CG, it is unconjugated hyperbilirubinemia. DR is autosomal recessive, means doctor is autosomal recessive, and Gilbert and Kriegler-Najjar type 2, it is autosomal dominant. Okay. Intensity of jaundice, it depends on basic, what is the basic defect. There is in type 1 Kriegler-Najjar syndrome, there is absence of UDP glucuronide transferase, and type 2 there is decreased activity, and in Gilbert there is decreased activity of UDP glucuronide transferase. Because this absence of UDP glucuronide transferase in Kriegler-Najjar syndrome, there is poor prognosis all of rest, excellent or good prognosis. And you have to remember Dubin Johnson syndrome. It, there is bromosulfation excretion test. This test has limited value for diagnosis of Dubin Johnson syndrome, but this test is must for diagnosis of Dubin Johnson syndrome. And there is greenish black pigment on liver morphology you can see. Now, second topic, neonatal hepatitis. Sorry. The other names of neonatal hepatitis is giant cell hepatitis or neonatal hepatocellular cholestasis. In general term, used for the constant morphological changes in conjugated hyperbilirubinemia. What are the causes? Either infectious or metabolic or idiopathic etiology will be there. Idiopathic etiology accounts for more than 75% of cases, and it presents in first week of birth with jaundice, with bilirubinuria, pale stool, and high serum alkaline phosphatase. Why bilirubinuria? Bilirubinuria is there because it is conjugated hyperbilirubinemia. So conjugated bilirubin is excreted in urine. So bilirubinuria is there. What are the morphological features? Irrespective of the etiology, either metabolic cause or infectious cause or idiopathic cause, histological features are the same. First feature is loss of normal lobular architecture of the liver. Second, presence of prominent multinucleated giant cell derived from hepatitis. So it is known as giant cell hepatitis also. Because presence of prominent multinuclear giant cells derived from these hepatocytes, it is also known as giant cell hepatitis. Mononuclear inflammatory infiltrate in portal tracts and some periportal fibrosis is there. Hemosiderosis is there. Cholestasis in small proliferated ducts in portal tract and between necrosed hepatocyte is there. These are the common morphological features in all form of neonatal hepatitis, either metabolic or infective etiology or idiopathic. Now we will discuss biliary atresia. Other name of biliary atresia is infantile cholangiopathies. What is it? It is a group of intrauterine developmental abnormality of biliary system. It is intrauterine developmental abnormality. Most commonly, it is congenital, but sometimes due to exogenous infection during the intrauterine development or shortly after birth that brings to inflammatory destruction of these bile ducts. It leads to biliary atresia. The condition may therefore have various grades of destruction ranging from complete absence of bile duct term atresia or reduction in their number means paucity of bile ducts. So two possibilities are there. Either complete absence of bile duct is there, it is known as atresia, or sometimes due to extraneous infection during intrauterine life leads to inflammatory destruction of bile ducts, lead to paucity of bile ducts, means reduced number of bile ducts will be there. What are the features of intrahepatic and extrahepatic biliary atresia? Here in intrahepatic, there is biliary hypoplasia is there. Sorry, spelling mistake. Biliary hypoplasia. Paucity of bile ducts is there. In extrahepatic, there is complete absence of bile duct. Atresia is there. What is common? It is ex- uh, seen in first week in form of cholestatic jaundice. Severe pruritus and dark urine is seen in intrahepatic cause. There is elevated transaminase is there. In extrahepatic cause, there is xanthoma is there. Remember, this extrahepatic cause are surgically treatable. And what is the procedure? Hepatic portoenterostomy is the procedure. So you have to differentiate intrahepatic atresia and extrahepatic atresia with the help of this kind of elevated transaminase. And in gross you can see dark green and large liver. Microscopically, what are the difference? Biliary hypoplasia, paucity of bile duct, and and in case of extrahepatic, atresia since birth or inflammations and sclerosis in perinatal period is there. And in intrahepatic, one more finding, increased hepatic copper will be there. Last point is Ray's syndrome. It is defined as acute post-viral syndrome of encephalopathy and fatty changes in viscera. Fatty changes in viscera means other than liver, it can affect various organs. What is the most common age? 6 months to 15 years. And what is the etiology? Either influenza A, influenza B, or varicella infections. This virus causes mitochondrial injury to the liver cells, and there will be elevated blood ammonia, serum transaminase, bilirubin, and prolonged prothrombin time will be there. Grossly yellowish orange color of liver is seen, and microscopically here you can see fatty changes in viscera. In case of Rett syndrome, what are the which organs are affected other than liver? First is kidney. You can see fatty change in renal tubular epithelial cells, fatty change in skeletal muscle cells, fatty changes hearts, and brain edema and focal necrosis of neurons are also seen. This completes first part about jaundice, and now we will discuss hepatic failure. Hepatic failure occurs when 80 to 90% of hepatic functions is lost. Whenever there is loss of 80 to 90% of hepatic function, ultimately it leads to hepatic failure. What is mortality rate? 80 to 90%. And what are the types? Either acute or chronic. Acute hepatic failure and chronic hepatic failure. Acute hepatic failure is due to massive hepatic necrosis and it carries worse prognosis. What can be the causes of acute hepatic failure? Fulminant viral hepatitis, acute alcoholic hepatitis, some hepatotoxic drugs, chemicals like carbon tetrachloride and mushroom poisoning. These are the various causes of acute hepatic failure. And causes of chronic hepatic failure are cirrhosis, chronic active hepatitis, chronic cholestasis, Wilson disease, and it is insidious and it has a better prognosis than acute. What are the complications of hepatic failure? If you know what are the functions of liver, then you can imagine what can be the complications of hepatic failure. These are the complications: hepatic encephalopathy, malnutrition, skin spiders or angiometaphyseal varieties. There is splenomegaly, periumbilical caput medusa is there, hemorrhoids and testicular atrophy, ascites. These are the complications. We will discuss all this. Jaundice, you know, function of the liver to metabolize bilirubin. Due to failure of liver cell to metabolize bilirubin, there is jaundice. Second, hyperkinetic circulation. Why there is hyperkinetic circulation? It is characterized by peripheral vasodilatation and increased splenic blood flow and cardiac output. Ultimately, this leads to reduced renal blood flow and perfusion results in tachycardia, low blood pressure, and reduced renal function. So it is hyperkinetic circulation is there. Third is hepatic encephalopathies or hepatic coma is there. What is the cause? Due to failure to liver cell to metabolize toxic products like ammonia and nitrogenous substance from the intestinal bacteria, which reach to systemic circulation and damage the brain. Normally, liver metabolize this ammonia and nitrogenous substance because there is functional loss of 80 to 89%, 90% of liver cell. This ammonia and nitrogenous substance reaches directly to the brain and damage the brain. So, hepatic encephalopathy is there. Hepatorenal syndrome. This is affecting liver plus kidney. And what is the finding? Acute renal failure with oliguria and uremia with good tubular function. Here, tubular function is almost normal and histologically it suggests a functional defect in the kidney. Then hepatopulmonary syndrome. In cirrhosis, pulmonary vasodilation is there with intrapulmonary arteriovenous shunting, leads to ventilation perfusion insufficiency and leads to clubbing of finger and cyanosis is there. So up to now we have discussed jaundice, hyperkinetic circulations and these three syndromes: hepatic encephalopathy, hepatorenal syndromes and hepatopulmonary syndromes. Now, coagulation defect. Due to impaired synthesis of coagulation factor, that ultimately it leads to DIC, thrombocytopenia, and increase in fibrin degradation products. There will be ascites and edema. Cirrhosis leads to portal hypertension, which leads to increased hydrostatic pressure, and liver failure leads to hypoalbuminemia, which leads to decreased plasma oncotic pressure. So, both diverse situations are there, increased hydrostatic pressure is there and decreased plasma oncotic pressure is there. These two mechanisms ultimately leads to leakage of fluids from vessels and formation of ascites and edema. Endocrine changes in male, feminization is there, formation, gynecomastia and testicular atrophy is there. In female, atrophy of gonads and breast will be there. In patients of hepatic failure, you can see arterial spiders or palmar erythema. And last step, Foeter hepaticus means sweetish pungent smell of breath. It is intestinal origin because liver fails to metabolize sulfur containing substance absorbed from the intestine. So sweetish pungent smells in the breath of patients of hepatic failure. What can be the life-threatening complications of hepatic failure? First is multi-organ failure. Coagulopathy leads to DIC, hepatic encephalopathy, hepatorenal syndrome. These are the life-threatening complications of hepatic failure. This completes today's lecture and some self-learning topics are circulatory disturbance like CVC liver, hepatic venous obstruction and portal venous obstruction. These are my references: Hersman 8th edition, Robinson Cotran 9th edition and Winthrop's Clinical Hematology. Thank you.